Good afternoon, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, Controversies in Obstetric Practice. It's my privilege to introduce the embassy of today's webinar, Dr. Nitya Ma'am. Ma'am is the consultant obstetrician, gynecologist, and fertility specialist at Institute of Reproductive Medicine at Madras Medical Mission, Chennai. I welcome you, ma'am, and I hand over the session to you.
Thank you, Sahiti. Good afternoon, everyone. Thank you all for joining us today for this exciting webinar on the topic, Controversies in Obstetric Practice. It is a pleasure to welcome you all to what promises to be a highly informative and engaging session. Today's webinar is a part of our ongoing efforts to tackle our day-to-day dilemmas in obstetric practice. We believe that through these sessions, we foster greater understanding and innovations. To mark the auspicious beginning of our webinar, we will commence with a lamp lighting ceremony. I would now like to invite Dr. Kundavi Shankar ma'am, who is the head of the department, senior consultant at Institute of Reproductive Medicine at Madras Medical Mission, to give the welcome address.
Thank you, Nitya. Good afternoon, and on behalf of IRM and Madras Medical Mission, we welcome all of our faculty and the delegates for this interesting webinar on controversies subject in obstetrics. We have the stalwarts here, and let's hear from the experts. And I'm sure the delegates will definitely benefit from this webinar. I really thank Dr. Suresha, Dr. Shanti ma'am, and Dr. Shobna, in spite of the busy schedule, to having accepted our invitation and being here. And I'm sure this is going to be a very interesting webinar on this various controversial subject. Let's move on to the webinar. Over to Dr. Nitya.
Thank you, ma'am, for setting the tone for the webinar. Throughout the session, we encourage all the participants to participate actively. Please feel free to ask questions, share your thoughts, and engage with our speakers and the fellow participants. You can use the chat box or the Q&A feature to submit your questions, and we will address them during the designated Q&A segment. I would like to invite our first speaker, Dr. Shobana Mahadevan ma'am, a consultant at Sitapati Clinic and Hospitals, Chennai. Madam has a special interest in high-risk pregnancy management and is actively involved in teaching programs. She will be sharing her expertise on antenatal steroids, offering valuable perspectives and actionable insights that we can all benefit from. Over to you, ma'am.
Thank you very much. At the outset, I would like to thank the organizers for such a very relevant program. Not only concentrating all the important topics in this field, but also on the controversies, because there is always something coming up newly every day and we don't know which one to follow. What was relevant, what was safe yesterday happens to be unsafe and riddled with controversies and problems today. And of all the topics are very well chosen. And my topic today, I can't overemphasize that it is something that is bread and butter for all the obstetricians. Are my slides visible now?
Yes, ma'am.
Yeah, okay. So why are we talking about antenatal corticosteroids? Because they are a very, very important intervention in the armamentarium of a practicing obstetrician. And the context in which we use this is in the preterm birth. Now my slides have to move.
Double click on the slide, ma'am.
It's not moving for me. Sorry.
Ma'am, to the bottom left, you will have some options, ma'am, to move the slides. You can click on the arrow. Yes, ma'am.
Yeah, now I can. Okay. So just to give the context, so India by its sheer number has the highest number of preterm births happening. And if you just to give a perspective about what is preterm labor, we have usually the preterm labor is defined as a delivery that happens between less than 37 weeks of gestation. But again, what is the earliest gestational age to say, okay, beyond this is preterm? We don't have a lower cutoff for this. This is because the viability as we define as a salvageability of a preterm fetus differs with the resource that we are talking about. In general, anything that is less than 28 weeks is called extremely preterm. And between 28 and 32 is very preterm. 32 to 34 is moderate preterm. And 34 to 37 weeks is called late preterm delivery. And it is important to know that majority of the preterm births occur in low-income countries. And not only that, if you look at the mortality of these extremely preterm babies, 90% of them actually do not survive in low-income countries, whereas only 10% die in high-income countries. So it's all the more important that we look at how to improve the perinatal outcomes in low-income countries. And these are all the different problems of a preterm baby. And if you look at this, in the context of the present topic of today, respiratory distress syndrome previously used to be called hyaline membrane disease. That is one of the commonest or the most important determinants of perinatal morbidity and mortality, apart from other things. Now, the various interventions that we have in our hand in order to improve the perinatal outcome, as you can see, the first and foremost effective intervention is antenatal corticosteroids. And we have tocolytics. We have magnesium sulfate for neuroprotection. We have antibiotics if we have preterm birth as a result of PPROM. And other things such as after delivery, the mode of delivery, and after delivery NICU care also important interventions in improving perinatal outcome. Now we have several guidelines to help us decide when to give and what to give in terms of antenatal corticosteroids. And we have this green top guideline from the Royal College of Obstetricians and Gynecologists. We have the updated WHO recommendation of 2022. And we also have Cochrane Library, which talks about all the important randomized control studies. And if you look at this, this is a Royal College infographic, which talks about who should receive, what should be given, when should it be given, how does it act, why should we give, and the uncertainties about which we'll talk today. And if you look at antenatal corticosteroids for fetal lung maturity, why do we give them? Because it causes significant reduction in respiratory distress syndrome, perinatal and neonatal deaths. It also results in moderate reduction in intraventricular hemorrhage and developmental delay in childhood, which is as a result of prematurity. Why do we give? When do we give? We give it in preterm labor, established preterm labor, PPROM, or when we plan preterm birth in an elective situation such as preeclampsia or a PPROM with a malpresentation in active labor. And we also have to know when we have to give this, when is it effective? We'll talk about this in detail a little later. And which medication? We have betamethasone and dexamethasone, which are the ones which are riddled with controversies. Will come in a minute. We'll talk about it in a minute. The important thing to know about the steroid administration is the best effect is seen 24 hours after the last dose, and the effect lasts 7 days. Now, this is the evidence we have for the routine use of corticosteroids. This is the traditional use. The gestational age should be between 24 and 35 weeks. A single course of corticosteroids, this is the key word, and there should be a reasonable prediction of preterm delivery within 7 days, and it reduces the perinatal death and RDS. This has a strong evidence. And why 24 weeks? Because this is the commonest age at which most centers would be able to salvage a preterm fetus. Why 34 plus 6 weeks? We'll talk about in a little while. Because the maximum morbidity of RDS happens between 24 and 35 weeks. After 35 weeks also, there is respiratory morbidity in the preterm fetus, what we call as a late preterm, 35 to 34 to 37. However, the overall percentage of complications in this late preterm group is slightly lesser, and therefore the balance between the benefit of giving the steroids and the risk of giving steroid becomes a little tilted. And what is the risk of giving steroids? We'll talk about it in a minute. And therefore, what does the evidence say? There is high certainty that it will reduce the perinatal death. If you can look at the risk reduction, it is 0.85, which means there is a definite reduction in the perinatal death, and neonatal death risk reduction is 0.78. There is moderate certainty about reduction in the intraventricular hemorrhage, though it says risk reduction is even better than the other two outcomes, 0.58. And reduces the developmental delay in childhood by a risk reduction of 0.51. Here, the evidence is not so strong as in reduction in perinatal death and neonatal death. But however, definitely there is an indication to give steroids for all these 4 reasons. But what are the challenges? There is a very short window of benefit. The benefit lasts only 7 days. And therefore, we need to be reasonably sure that the preterm birth will happen within those 7 days. If we give without enough precision in accuracy in predicting preterm labor within 7 days, we may be actually over-treating. If we don't want to over-treat and we want to go closer to the time of delivery, sometimes the delivery itself will happen and we may be under-treating. And therefore, if we give the steroid and then the pregnancy goes beyond 7 days, we may be compelled to repeat the dose, and there is a potential for harm with multiple doses. These are the issues. So let us see one case scenario. 34 weeks primary IVF conception, type 2 diabetic, with good glycemic control. Her delivery is planned at 36 weeks for whatever reason. Should I give steroid? We know that there is evidence to support the use of steroid up to 34 plus 6 or 35 weeks. But can we push it a little longer? Give it at 36 weeks. And what will go wrong? Why can't we give? This is a common scenario, right? So the evidence for this question comes mostly from the antenatal late preterm study. It was a multi-center, double-blinded, placebo-controlled RCT. If you look at most of the studies, we talk about the benefit of antenatal corticosteroids. They would have stopped with 34 plus 6. So this is a study that was exclusively done to understand whether it will be effective in late preterm babies. So in this study, preterm labor with intact membranes, spontaneous preterm labor, anybody who had spontaneous rupture of membranes in the late preterm gestation, or we electively plan to deliver them in the late preterm. All these patients were included. And there were some strict exclusion criteria. So if you look at the bottom box, the neonatal composite of the outcomes were looked at: respiratory treatment, stillbirth, neonatal death, which occurred up to 72 hours. There was a risk reduction of 0.80. So there is some evidence to say that, yes, if you were to administer them for a high-risk group between 35 and 37 weeks, there may be a benefit. Okay, then what is the problem? So if you look at this study, this is often quoted study for the benefit of steroids in late preterm, 35 to 37 weeks. Again, it says reduced need for respiratory support, but there is a higher risk of neonatal hypoglycemia. And why are we worried about hypoglycemia? Because neonatal hypoglycemia is one of the reasons for developmental delay. And therefore, we need to be cautious about this. If you look at the bottom line, the overall incidence of RDS, TTN, need for surfactant therapy did not differ significantly. And so we need to really think, should we really be giving beyond 35 weeks till 37 weeks? So this is another study which looked at long-term outcomes in late preterm births between 35 and 37, which looked at the outcome at 5 years of age. Somebody who had received antenatal steroids in late preterm, there was an increased risk of suspected neurocognitive disorder. But if you look at the hazard ratio, it is not a lot, it is only 1.1. And the need for audiometry testing was about 1.2, visual testing was 1.0. It's not a lot because we don't have such a large evidence to say that it is, we don't have large numbers looking at the long-term outcome, but there is a suggestion. There is a suggestion that it could be potentially harmful. So the overall thing to say is there is a reduction in need for respiratory support, which comes out of a Cochrane review of a single trial, but there can be likely neonatal hypoglycemia may cause behavioral problems. So when you look at these studies, there will always be a number called NNT, number needed to treat or number needed to harm. So now this is a number needed to harm. So if you treat 11, you need to treat 11 people with late preterm labor with corticosteroids, that you can have one neonatal hypoglycemia. Behavioral problems is even less common. You need to have treated 38 pregnancies to have one case of behavioral problem. Now, so the updated guideline in WHO clearly says, I'm going to read this out, until robust evidence shows an improved balance between benefit and risk becomes available, particularly from low-resource countries, restricting antenatal steroids to neonates with a gestational age of less than 34 weeks is a reasonable safeguard to prevent unsafe antenatal corticosteroid use, especially considering the challenges in accurately estimating gestational age in the late third trimester. So we shouldn't be using them left, right, and center. What does the RCOG guideline says? In very late preterm gestation, the use of steroids should be considered in the light of balance of risks and benefits, which means we need to sit with the woman and counsel, and we need to be clear, what are we giving it for? What is the actual risk of respiratory distress in this baby at this gestational age? ACOG, so if somebody has not received a previous course, obviously, it recommends, it can be considered recommended up to 37 weeks. So we'll go to the next controversy. We looked at late preterm, extending the usage for 35 to 37 weeks. Now, somebody who has reached 37 weeks, we are planning an elective section. Should steroid be given? Again, this is a very often confused topic because RCOG Green Top guideline says it can be considered if you have an elective section for 37 weeks. Again, the evidence is very, very moderate degree of evidence. So if you give it between 37 and 39 weeks, what is the advantage? It reduces the need for NICU admission for respiratory morbidity. But we are not certain whether the overall NICU admission due to various other reasons is reduced. There is the potential for hypoglycemia, just like giving it for late preterm, and there is a potential for developmental delay. This comes out of a Cochrane review of low to moderate evidence of a single trial. So look at the need for respiratory distress at 37 weeks. It is extremely low, less than 5%. It is usually mild and transient, and there is low certainty of benefit. And therefore, clinicians should discuss these factors with the woman when considering the administration of steroids prior to cesarean section at term. When I say term, it is between 37 and 39 weeks. I hope and I'm sure nobody is going to give it beyond 38 weeks. So what is the overall message? Benefit of antenatal corticosteroids in reducing respiratory morbidity decreases with gestational age, with number needed to treat actually increasing and number needed to harm is also decreasing. And this applies to term elective C-sections also. The primary aim should be to delay the delivery to 39 weeks whenever possible. I think this is what we should be really aiming for instead of jumping and giving corticosteroids. Whenever we know we have to plan, say, for example, a previous cesarean section, we are planning to do an elective C-section. Instead of doing it at 37 and 38 for social reasons, if we can push it to 39, we can definitely decrease the respiratory morbidity. We are not going to be bailed out by giving steroids when we plan an early delivery, because it comes with certain complications and risks long term. So because there is conflicting recommendation in the late preterm and term, be very cautious in using them. And neonatal hypoglycemia, if you look at any small study, whenever it was given for late preterm and term, this has been a consistent finding, and neonatal hypoglycemia is a marker for developmental delay. Now, we'll go to the other extreme. How early can it be given? Say, for example, somebody comes in, you are in a tertiary center where somebody comes in with PPROM at 24, maybe 23 plus 4, 24 weeks. Would you give steroids, and your neonatologist is confident that they can salvage the baby? Is steroid going to be really effective in reducing the respiratory complications? There are some studies coming up, and there are many observational studies. There is one systematic review, and therefore we have some evidence now. So it has a beneficial effect in reducing the neonatal death. So this is an old study, but this has been also proved in recent studies. As you go from 22, 23, 24, 25 weeks, at every gestational age, when you compare giving and not giving antenatal corticosteroids, there is a small improvement in the outcome if you give corticosteroids. So we can definitely consider this, have a discussion with the neonatologist about the salvageability. If they are confident that the baby can be salvaged, and if you think there is a high possibility that the baby will be delivered within 7 days, you can go ahead and give. So the next controversy is what steroid to give. Is it betamethasone or dexamethasone? I think this controversy has been resolved with the Government of India initiative saying that dexamethasone should be given. So there are many studies now very clearly saying they both are equally effective. Previously, there was a preference to give betamethasone because dexamethasone, we thought we'll have to give it every 12 hours or even every 6 hours. But recent studies have shown that in the same dosage schedule as betamethasone, we can give dexamethasone 12 mg 24 hours apart, and they are both are equally effective. So the dexamethasone is listed in the WHO essential medicine list. It is inexpensive and widely available in facilities for multiple indications. The other problem with betamethasone is that in India, the salt that we have is betamethasone phosphate, whereas all the trials and abroad, they have used the combination of betamethasone acetate and phosphate, which is not available here. And therefore, now that both are equally effective and dexamethasone is also inexpensive, there is definitely, it is a preferred medication. And therefore, WHO Action 3 trial shows safety and efficacy of dexamethasone when given to women at imminent risk of late preterm birth is been proven. But again, the dosage schedule in recent trials has been definitely shown to be 12 mg 24 hours. Now, the overall question whether the administration of steroids cause long-term neurodevelopmental delay. If you look at the study that came out in JAMA in 2022, so this took into account all the people who received steroids with a suspected preterm labor. And this showed that if you take preterm babies born preterm with extremely preterm birth, and those who received antenatal corticosteroids had a significant reduction in neurodevelopmental impairment. There is no doubt about this. They need to be given. If you look at children who finally delivered late preterm between 35 and 37 weeks, actually in this group, there was higher risk of neurocognitive disorders. If they had gone on to deliver in full term, there was a higher risk in mental and behavioral disorders, as well as proven and suspected neurocognitive disorder. So this is low certainty. This is low certainty. There's evidence is not very strong, but we need to keep this in mind. This is shown in this infographic. What is important to know is that half of the babies who have received antenatal corticosteroids preterm, actually half of them go on to delivering after 37 weeks. This is something that goes to show that we are not that good in predicting preterm labor. And other modalities such as cervical length examination are all coming up, so that we are our prediction of preterm labor within 7 days has to be better. But if they were given before 34 weeks and they did not deliver preterm, they go on to delivering late preterm or term, you can see there is a 50% increase in the behavioral disorders and 15% increase in neurocognitive disorders. But if they delivered preterm, if you gave them preterm and they delivered preterm, there is a 30% reduction in neurodevelopmental impairment. If they develop late preterm, say 34 to 36 weeks, actually the neurocognitive disorder goes up by 10%. So this is something that we need to keep in mind before administering dexamethasone for not, standard recommended situations. I'm not going through this. It comes out with the same. So we'll go to the next scenario. If you look here, 30 weeks gestation, painful uterine contractions with 3 centimeter dilated. She's febrile, 100 degrees with shivering, urine examination suggestive of UTI. You know she has a urinary tract infection, but we haven't got back the urine culture report. She is having temperature. Will you give steroids? Because steroids, we know, can accelerate the course of septicemia. So when is steroid indicated? Is it contraindicated in the presence of infection? Now, again, if the infection is due to an isolated focus, that could have possibly triggered the preterm labor, say like typically a urinary tract infection, steroid should be given because it overall improves the perinatal outcome and does not worsen the infection if we give it under antenatal antibiotic cover. If there is a systemic infection with septicemia, definitely we should be more cautious. It should be weighed against the benefits. And do not, if there is sepsis suspected, do not wait for the steroid to be effective. You have to just go ahead and deliver if there is chorioamnionitis. This is something that should be the recommendation. So generally, if there is an isolated focus of infection, you can give steroids. If there is septicemia, you have to weigh the risk against benefit and do not delay the delivery. And we'll go on to the next scenario. Somebody 28 weeks admitted with pains with a BP of 160 by 100 with a 1+ of proteinuria. She was given steroids. Her BP was well controlled. She did not deteriorate. And then she was discharged, followed up regularly. Now she's 32 weeks and she develops a blood pressure of 160, 110. Her proteinuria has worsened and admitted. Now you think you're going to deliver her. Now the previous steroid was given 1 month ago. So should we repeat the steroids? Previously, there was strong evidence that repeated courses will cause more and more neurodevelopmental delay. But now the recent studies do not have a strong evidence for that. And therefore, should we be giving the steroids? Why does she need a multiple dose of steroid? This is because the effect of steroid is temporary and we are not able to precisely predict the risk of preterm birth. And therefore, some studies, actually randomized control studies, looked at giving multiple doses, and these studies consistently showed one thing. The earlier studies, people used to give every week because it lasts only 1 week. Multiple doses giving every week, but particularly in IVF setup, this used to happen. And they noticed that the baby went in for fetal growth restriction and the birth weight was significantly less. And then the Cochrane, the recent review also has answers for this. So if you look at whether these benefited, these babies benefited in terms of RDS, yes. If the baby received another dose because the previous dose was given long time ago, the RDS is reduced. The probability for severe lung disease is reduced. But the evidence could not exclude benefit or harm for fetal or neonatal or infant death. It definitely reduced the risk of RDS. What does the WHO says? If there is significant risk of preterm delivery in the next 7 days and have received the single course at least 7 days before, we can repeat a course, not multiple courses. We can repeat a course. NICE says counsel them about a smaller birth weight, and therefore overall message is, if she is still less than 34 weeks, do not give them if they cross 35 weeks. If they are still less than 34 weeks and the previous dose was more than 14 days before, and if you suspect a high possibility of delivery within 7 days, this is also very important. Say, for example, she received the dose 1 month ago and she has come to 34 weeks, but she's not at risk of delivering in the next 7 days. You don't have to repeat it. Remember that. Okay, this situation will primary 29 weeks admitted with 4 centimeter dilatation. You know for sure she is going to deliver within the next 12 hours. Would you still give steroid? Because we know that the maximum effect of steroid is 24 hours after the last dose. Now we have time only for 1 dose, and that too less than 12 hours. Is it going to be effective? So the evidence is that though maximum effect is 24 hours to 7 days after the second dose, benefits are seen even if birth happens within 24 hours of the first dose. So WHO does not say benefit is there, but the recent update, it can be discussed with the patient. That is what the WHO guideline says. So I have come to the end of my presentation, covering some of the controversies with antenatal corticosteroids. I would be happy to take any questions.
More a comment, Shobana. Excellent evidence-based approach to that presentation. Really like the way you presented with all the evidences. Wonderful. My only query is, when you are talking about the infections, what did you mean by a focal infection you can give? What was the message there?
So I was talking about an infection restricted to an organ. The commonest one is the UTI, which is the commonest trigger for a threatened preterm labor. So people will have fever, shivers, a temperature, and there is generally a reluctance to give steroids in the presence of sepsis, right? It's not septicemia as in patient having hypotension and organ dysfunction and all that. So steroids will worsen the sepsis, and therefore there is a general reluctance. But again, a lot of times this kind of pyelonephritis is the reason why she is actually going in for preterm labor, and the baby is at risk of all the complications of preterm birth. In this situation, the administering steroids is not going to make her go for septicemia. The other possibility is independently she's having a pneumonia, and then she's also going in for preterm birth. Can we give steroids when she's having a pneumonia? Those kind of situation we can give, of course, under antibiotic cover if it's a bacterial infection. If there is sepsis, focal sepsis that has gone on to a systemic septicemia, now steroids, again, some people give steroids to stabilize the endothelial dysfunction. Some people, there is also the other thing that steroids will aggravate the septicemia. So that you have to weigh the pros and cons, and it is a collective decision with the ICU, intensivist and all we have to decide. But in general, just because somebody has a fever, tachycardia and focal, not systemic, but focal sepsis, you can give steroids. It's safe.
Ma'am, we have some more questions.
Yeah.
Would you like to take them at the end?
I can answer them now. I think we have some time. Are we running late?
Yes, ma'am.
Late?
Yes.
Okay,
So, ma'am, if you could stay back, we'll take the questions at the end, ma'am.
no problem.
Sure. Thank you so much, ma'am.
Thank you.
Truly appreciate the time and efforts you have put into sharing your insights with us today, ma'am. Thank you so much.
Thank you.
Our next topic is oligohydramnios. It is my distinct pleasure to introduce and welcome our next esteemed speaker, Dr. Shanti Gunasingh, ma'am, who is a consultant obstetrician and gynecologist at Mangalam Healthcare, Chennai, former director at IOG and ISO KGH. She was also our past president at OXY. Over to you, ma'am. You didn't share the slide, Sahiti?
One minute.
Yeah.
Minute.
Yes,
Thank
ma'am.
Yeah.
Thank you, ma'am.
Can you see my screen now?
Yes, ma'am.
Yeah. Good afternoon to one and all. I thank Dr. Kundavi and Dr. Nitya for having given me this opportunity. My topic is oligohydramnios, controversies in obstetric practice. So we will go to one case scenario. A 26-year-old primigravida with 26 weeks pregnancy comes for routine antenatal checkup. Her last antenatal checkup was at 21 weeks when she had her anomaly scan, and she was told that it was normal and she has no comorbidities. Now she has come and the uterus is about 24 weeks and full of baby. That is, like clinically seems to be less. So what will be the diagnosis? So probably it can be oligohydramnios plus or minus fetal growth restriction. So what is oligohydramnios? It refers to amniotic fluid volume that is less than the minimum expected for the gestational age. So it is about less than 1% of preterm pregnancies and 2 to 10% of pregnancies at 40 to 42 weeks. So we know that amniotic fluid is a dynamic thing which keeps on changing, and it starts increasing. Around 10 weeks, it is about 10 to 20 ml. It reaches a peak around 33 weeks and then remains plateaus to a certain extent. And then later in gestation, it starts falling. So in the second half of pregnancy, amniotic fluid is produced by the fetus as urine and lung liquid and resorbed by fetal swallow. Another pathway also we have for amniotic fluid reabsorption, that is the intramembranous pathway, which is fluid movement across the amnion into fetal vessels on the surface of the placenta. The rate of fluid resorption through the intramembranous pathway adapts to maintain normal amniotic fluid volume. A lot of fetal and maternal conditions can cause variations in fetal homeostasis and affect amniotic fluid volume by altering fetal urine production that we well know by the abnormal fetal kidneys, or by swallowing. When there is problem there also, it can result in polyhydramnios and possibly lung liquid secretion. Thus, amniotic fluid volume is a passive reflector of the fetal conditions. So this patient, we know she's having oligohydramnios. So what can be the causes? So maternal, we have to look for medical or obstetric conditions associated with uteroplacental insufficiency, like preeclampsia, chronic hypertension, collagen vascular disease, nephropathy, or thrombophilia. And proper drug history is mandatory, especially angiotensin converting enzyme inhibitors, ARBs, prostaglandin synthetase inhibitors like NSAIDs, and trastuzumab. Diabetes insipidus, rare cases have presented with oligohydramnios that improve upon maternal treatment with desmopressin. Placental abruption, especially chronic abruption, and twin-to-twin transfusion and trap sequence, where we see it in the donor twin, placental thrombosis or infection, and coming to fetal causes, mandatory to rule out chromosomal abnormalities, congenital abnormalities in the fetus, especially those associated with impaired urine production or excretion. So both production as well as obstruction, that is the outlet obstruction, we have to specifically look for. Growth restriction, fetal demise, for post-term pregnancy, ruptured fetal membrane. So any case of oligohydramnios, mandatory to rule out ruptured membranes, and infection, especially parvovirus and all that can cause, and idiopathic. So how do we diagnose? So diagnosis is based on measuring amniotic fluid. So generally, OGCNs are very fond of doing amniotic fluid index less than, so anything less than 5 centimeter is oligohydramnios, although it differs with gestational age. So we just measure the vertical pockets. We divide the maternal abdomen into 4 quadrants and then add up all the fluid levels. So the single deepest pocket less than 2 centimeter is very important. So what is the controversy here? So single deepest vertical pocket or amniotic fluid as evaluation test for predicting adverse pregnancy outcome. This is the SAFE trial, a multi-center open-label randomized control trial. So here they came to the conclusion that use of AFI method increased the rate of diagnosis of oligohydramnios and labor induction, unwarranted labor induction for oligohydramnios without improving perinatal outcome. Hence, the single deepest pocket is the favorable method to estimate amniotic fluid volume, especially in a population with many low-risk pregnancies. Probably in polyhydramnios, AFI will be a better indicator. So how do we measure SDP? So ultrasound transducer is held perpendicular to the floor or perpendicular to the uterine contour when obtaining the measurement. Fluid pocket should not contain fetal extremities on grayscale examination, and measuring the largest unobstructed amniotic fluid pocket that is at least 1 centimeter. There is no role for color Doppler at all for measurement, but then to establish the absence of umbilical cord for pools of amniotic fluid, where this is not certain, probably it is permissible. So what do we do now? Thorough maternal and family history and targeted physical examination to look for maternal and familial conditions which I had elaborated earlier, that may be associated with oligohydramnios. Maternal medication is very important, and we have to rule out pre-labor rupture of membranes by doing a speculum examination with a sterile speculum. And if necessary, probably we can, if she complains of draining PV, then probably we can even use these kits which are commercially available. Detailed sonographic evaluation for findings that may account for reduced amniotic fluid volume. Assessment of fetal anomalies is mandatory, as I said earlier. Kidneys, bladder, umbilical cord, fetal insertion site, and vessel number. Fetal sex, all these problems are more common with male gender. Second trimester markers suggestive of aneuploidy, fetal growth restriction, and placental anomaly. So, if fetal anomalies are identified, offer fetal diagnostic genetic testing in the form of amniocentesis or cell-free DNA. Probably, what is the role now? So much, all these exome sequencing, all these things are being done. So only in a case of recurrent oligohydramnios and where previous autopsy has not thrown any light, probably in those cases, it might be helpful. So what are the types and frequency of congenital anomalies associated with oligohydramnios? Renal tops the list with 65%, but multiple anomalies can be seen, and aneuploidy is about 8%, central nervous system 5%, skeletal system 4%, CVS 3%, and others 4%. So what is the role for diagnostic transabdominal amnioinfusion? This is indeed controversial, especially see it is mandatory to rule out fetal anomalies if she has not had a proper scan earlier, or sometimes anomalies can evolve later too. So in that event, probably a diagnostic transabdominal amnioinfusion of 200 ml of saline under ultrasound guidance to provide better visualization of fetal anatomy and thus improves diagnostic precision. It temporarily increases amniotic fluid volume. And if any genetic material has to be taken also, then that can be done. And a case of PRM also, if the dye is instant, then the draining can be made out well. Is there a role for fetal MRI? Routinely, no. But then it can be helpful to better define complex fetal anomalies when this information will alter patient care, as it is less limited by lack of amniotic fluid than ultrasound. But then we should understand that oral rehydration of the mother with 2 liters of water over 2 hours may be an alternative to amnioinfusion. This will transiently increase amniotic fluid volume for up to 48 hours, particularly in hypovolemic patients. So last month, when our patients were really dehydrated with the scorching sun, as well as long waiting hours, probably all these things will really go a long way in making a proper diagnosis. Hydration with water reduces maternal plasma or osmolality and sodium concentration, resulting in osmotically driven maternal to fetal water flux. It also improves perfusion. What is the role of intravenous hydration? So earlier we used to give lot of IV fluids, but then isotonic fluids, hypotonic fluids are better than isotonic fluids. Like, so 0.45% normal saline or 0.25% normal saline. Those are more helpful than the isotonic fluids like RN. And oral water injection and desmopressin markedly and transiently increases amniotic fluid volume. But then this is only done under experimental settings. What is the role of Doppler? We always associate oligohydramnios with Doppler. But then there is no clear role for Doppler imaging in the evaluation of fetuses with kidneys and isolated oligohydramnios. That means we have oligohydramnios, but there are no other comorbids. So, but it can be used to assess for the presence of renal arteries when kidneys are not well visualized, since failure to image renal vessels using appropriately low gain setting is suggested, although not definitive evidence of renal agenesis. So especially in early oligohydramnios, all these become very crucial. So what lab testing is warranted? No routine testing is required, and testing for maternal serum or amniotic fluid for an infection-related pathology will depend on the degree of suspicion. Maternal history like fever or contact with such persons, symptoms, and other fetal abnormalities on ultrasound. If maternal serum alpha-fetoprotein had been performed, in some centers, they routinely perform one at 15 to 20 weeks. If had been performed and elevated, it has prognostic significance and can be helpful in counseling. But it is not mandatory at all to have it done now. So elevated maternal serum alpha-fetoprotein may be due to leakage of amniotic fluid from the vagina or transplacental passage of fetal blood into maternal circulation. The fetus may or may not be anomalous. Elevated maternal serum alpha-fetoprotein and decreased amniotic fluid volume has poor prognosis, fetal growth restriction, fetal death, preterm birth, and neonatal death. So this patient, we have identified oligohydramnios. So how do we counsel? So fetal and neonatal prognosis depends on the etiology, like if it is preeclampsia, severe, all that, and its severity too, and gestational age at onset and duration of oligohydramnios. Pregnancies with renal oligohydramnios, that means with fetuses who have abnormal kidneys, should receive multidisciplinary counseling and further evaluation. Idiopathic oligohydramnios, where only oligohydramnios is present, no other incriminating factors or comorbidities, has a better prognosis than renal oligohydramnios, but the risk for adverse outcome is still increased because some of these cases represent placental pathology, maternal vascular malperfusion. So always we think it is only idiopathic oligohydramnios, but sometimes it can be a manifestation of maternal vascular malperfusion too. So we have increased risk of meconium aspiration syndrome when compared to normal amniotic fluid volume, 1.4 versus 0.2%. Cesarean birth for an abnormal fetal heart rate pattern, 4.2 versus 1.4%, and NICU admission, 8.7 versus 3.7%. So even idiopathic oligohydramnios probably has certain problems. Although subsequent papers, many of them clearly keep on stating that there is no abnormal neonatal problems. Adverse neonatal problems. Patients with oligohydramnios and comorbidities, excluding fetal anomalies and PROM, are at increased risk for low birth weight. Potential sequelae of cord compression, fetal demise, postnatal asphyxia, or meconium aspiration syndrome, preterm birth, and neonatal abnormalities, skeletal deformations, contractures and pulmonary hypoplasia, especially when the duration is prolonged. And oligohydramnios after PPROM. Pulmonary hypoplasia is less than 1.4% if it occurs after 26 weeks, but earlier it is very high. And this can result in morbidity and even mortality. Lower volumes of residual fluid confer the higher risk. Oligohydramnios associated with uteroplacental disorder like fetal growth restriction, abruption, preeclampsia depends upon the prognosis of the underlying disorder. Sometimes we see oligohydramnios after amniocentesis, but usually membranes often seed and pregnancy outcome is quite normal. So how do we manage? Therapeutic maternal hydration is mandatory. This can be oral or it can be intravenous. And we also talk about hydration and sildenafil citrate after 30 weeks. So sildenafil citrate, 25 milligram thrice daily and 1 liter of IV hydration followed by oral hydration significantly increase the AFI. But what is the controversy about the Strider trial was halted? This was actually poor outcome, early onset oligohydramnios. And this was halted study of all these cases. And this was halted because of the higher rates of lung disease and death of newborn in intervention group. So we really actually the study population seemed to be entirely different. Isolated oligohydramnios is different and the other ones are different, especially early onset. But then we have to be really, the last word has not yet been said, so probably we still cannot use sildenafil. And amino acid infusion is used a lot. Is it really evidence-based? Although guidelines do not talk about that, but then we have few papers. This is the effect of amino acid infusion on AFI in pregnancies associated with oligohydramnios and fetal growth restriction too. So here, IV amino acid was given on alternate days for 3 days, and IV hydration was given for about 2 weeks. So they found that this was an effective modality for treating oligohydramnios associated with fetal growth restriction and with a strong positive impact on the amniotic fluid index after 7 and 14 days of implementation. The rate of vaginal delivery, then there is increased baby weight at birth, better APGAR score at 1 and 5 minutes, as well as lesser neonatal complications were seen. But then guidelines do not advocate it. What about L-arginine, which also is used from fertility, people aspiring fertility and till the adults? It seems to be a Sarvaroga Nivarani now. But then what is the controversy about this? This is a precursor of nitric acid and plays a role in local vasodilatation. It is actually suggested to improve amniotic fluid index in oligohydramnios. So this is a paper published in our Jogi, role of L-arginine in oligohydramnios. This study was conducted in Wardha in a rural hospital for 2 years. And L-arginine supplementation is promising in improving volume of amniotic fluid in cases of oligohydramnios and prolonging pregnancy for a mean of 2.4 weeks, allowing fetal lung maturation, thus benefiting the neonatal outcome. But then we know it is not, we take arginine for granted a great deal, but then this can have interactions with lot of drugs. So that also we should understand, especially if they are on heparin. So we have to be really very careful. So this is yet another paper which talks about the effect of L-arginine on AFI in oligohydramnios. It definitely increases the AFI. So what about the subsequent prenatal care? So we have to do a non-stress test and evaluate, especially if it is after 28 weeks, because earlier it might not be very helpful, and evaluate SDP once or twice weekly until birth, depending upon the maternal and fetal condition. Combined use of NST and SDP is associated with a low rate of unexpected fetal death. Serial sonography examination every 3 to 4 weeks to monitor the fetal growth. But the controversy is a routine use of Doppler, which is indicated to monitor pregnancies only with fetal growth restriction. And this is a paper, a review of literature, which talks about borderline or marginal amniotic fluid index and peripartum outcomes. So we say if AFI is used, then from more than 5 and less than 10, or probably even 7 now. All these things come under borderline or marginal amniotic fluid. But then it has been noted that there is a clinical benefit of intervention is not at all reasonable, and we have to continue with antepartum care dictated only by other obstetric factors. Otherwise, no need for intensive follow-up. What about timing of death? Oligohydramnios of known etiology, then we have to follow those conditions. Preeclampsia, if she develops severe preeclampsia or health, then naturally we have to turn. PROM, expected management, and certain adverse effect, adverse things crop up, like probably infection, or she gets into labor, then we have to deliver. And fetal growth restriction, of course, if it is early onset, then 34, not more than 34 weeks. So 32 weeks if it becomes really intense. So all that depends on the intensity. If it is a late onset, probably not more than 37 weeks. We have to turn. Congenital anomalies, accordingly, we will tell. Post-term, we can induce. What about idiopathic oligohydramnios or isolated oligohydramnios? ACOG recommends delivery at 36 to 37 weeks, 6 days of gestation, or at diagnosis if diagnosed later. But we have to consider the clinical scenario for past obstetric history and patient preference in the timing of delivery, regardless of Bishop's score. Alternately, the patient can be followed with serial NSTs and biophysical profile to be delivered not later than 39 weeks. So this is paper, Amniotic Fluid Index and Oligohydramnios, a deeper dive into the shallow end. So SDP is preferred to AFI for performing amniotic fluid volume assessments. Available data demonstrated significantly improved maternal and perinatal outcomes with a policy of labor induction at or beyond 37 weeks of gestation versus a policy of expected care. So this was what was generally considered. And what about the route and site of birth determined by obstetric considerations? Although the chances of cord compression and cesarean birth are increased, vaginal birth is often successful. But then neonatal care level should be appropriate for the potential respiratory and renal needs of the newborn. Sometimes all these newborns who have abnormal kidneys, they might even need to have renal replacements for months together, or might even need other drastic interventions. Continuous electronic fetal monitoring, given the increased risk of cord compression, but most patients will have a normal tracing. And what is the controversy about transcervical amnio infusion for patients with oligohydramnios and variable fetal heart decelerations in labor? So routinely earlier we used to give amnio infusion, but now it is not done anymore unless if you really think probably they can benefit from this so that cord compression does not occur. But then with variable fetal heart deceleration and in labor, we should really have the heart to give amnio infusion rather than take up for C-section. This is an original article from Pakistan. Isolated oligohydramnios is not an indicator for adverse perinatal outcome and should not be an indication for induction of labor as was earlier thought to be. That is 36, 37 weeks. That is now the thing. This is yet another one published in BJOG. Isolated oligohydramnios is not associated with adverse perinatal outcome. And we have yet another paper from US, although ACOG says 36 to 37 weeks. Lehman and Almond, they have said that assessment of the pregnant women with oligohydramnios, this is mainly only for term. So a woman who has pregnancies between 37 to 41 weeks, AFI less than 5 or SDP less than 2. We have to evaluate for ruptured membranes, review pregnancy dating, do a non-stress test to evaluate the fetal well-being, then determine presence of pregnancy-induced hypertension, diabetes, or other comorbids, and any uteroplacental insufficiency, and USG for ruling out fetal growth restriction and anomalies, even at this stage, although we might not be completely ruling them out. So if any abnormalities are revealed in any of these tests, we have to induce labor. If it is no abnormalities at all, it is just isolated oligohydramnios, initiate maternal hydration, 2 liters over 2 hours, measure the AFI again in 2 to 6 hours. If the AFI still doesn't improve, consider inducing labor. If the AFI improves, perform AFI measurement and NST weekly or even twice weekly. So as adverse fetal outcomes have not been demonstrated, these people are very categorical. Earlier also, there were a lot of papers which were saying we were having adverse effects. But then now all the recent papers talk about just observation. There is no rationale for routinely inducing labor based on an isolated finding of a so-called borderline amniotic fluid index that is 5 to 8 range. Even in less than that, probably, as said earlier, only if indicated. And this is yet another paper by Scherer and Urlanger about oligohydramnios use and misuse in clinical management. So they have said that recent evidence is accumulating that in the presence of one appropriate for gestational age fetus, that means fetal growth restriction is ruled out with reassuring fetal well-being. Here they talk not only about NST, but also about the Doppler velocimetry of the umbilical artery and the absence of maternal disease. Oligohydramnios is not associated with an increased incidence of perinatal outcome. Accordingly, given the poor current sonographic capability to correctly diagnose decreased amniotic fluid volume and the reported transient nature of oligohydramnios, that is very important, and evidence that amniotic fluid volume may be increased with maternal hydration, it appears that induction of labor at term for decreased amniotic fluid volume cannot be just taken for granted, but instead should be reconsidered. And they also say that in an attempt to decrease the overdiagnosis of isolated oligohydramnios, they wonder whether strict uniform maternal hydration status criteria be implemented prior to ultrasound assessment of amniotic fluid volume. Should OGCS tell them that they should keep on drinking water prior to that? This would clearly assist in avoiding inadvertent inclusion of relatively dehydrated women in whom oligohydramnios may reflect a transient and correctable finding. Should patients with isolated oligohydramnios at term continue to undergo induction of labor, we have to really think over. And should other less invasive management paradigms of the patient at term, this can probably include increase in maternal volume intake, either oral or intravenous, and subsequent reassessment of amniotic fluid volume be entertained. Or finally, they have mentioned, I think probably our fetal medicine specialists can throw light on this. What is the significance of full or distended full bladder noted in conjunction with isolated oligohydramnios? We also have papers which talk about the hourly fetal urine output being normal in isolated oligohydramnios. People talk about the aquapores, that is the water systems, which are different. So alternatively, should any bladder measurement be considered when diagnosing oligohydramnios? So this is from the Society of Maternal and Fetal Medicine. Perinatal outcome in pregnancies complicated by isolated oligohydramnios diagnosed before 37 weeks, that is preterm. So active management in cases of isolated oligohydramnios at preterm actually seems to increase the perinatal morbidity. So it is very important not to routinely deliver them quite early or even before 39 weeks. That is what they say. Okay, so coming to scenario 2. 27-year-old primigravida with 21 weeks gestation came for anomaly scan, severe oligohydramnios. Okay, nearly bordering on to anhydramnios. Only a rim of fluid is there. So on inquiring, it was found that the patient had been taking diclofenac for low back pain. She was advised to stop the drugs, hydration advice, reviewed with scan 2 weeks later, found to have normal liquor. Structural survey could be done now. Kidneys were normal. Fetal anatomy normal. She had a good obstetric outcome. So it is mandatory that they should be aware that they should not take non-steroidal anti-inflammatory drugs. But so many times it is reversible. Sometimes a long-standing, it can have an impact on the fetal kidneys. But then we should understand still it can be reversible as evidenced by this case. So this is a paper which talks about reversible oligohydramnios in the second trimester of pregnancies in 2 patients with long-term diclofenac exposure. These patients were diagnosed with severe oligohydramnios at 22 and 23 weeks, and they were taking up to 150 milligram per day. But then amniotic fluid became normal after discontinuation of diclofenac. Although early onset oligohydramnios is a very complex complication, we have to be wary of all these things. And use of NSAIDs, if indicated, should be considered when maternal benefits outweigh the potential fetal risk at the lowest effective dose for shortest duration. Suppose she has had a fracture or some heart. On beyond 48 hours of NSAIDs treatment, ultrasound monitoring of amniotic fluid should be considered and stopping therapy if a decline in AFI is present. Coming to scenario 3, she's a 32-year-old primie. This primary found to have anhydramnios on targeted imaging for fetal anomalies. No complaints of leaking pee. So on detailed medical history, she was found to be on losartan since 4 years. She was advised, she had been having regular antenatal checkup, but still it had been missed. Probably she did not tell her OGCN. She was advised to stop the drug and was put on tablet levodopa. Scanned repeated after 2 weeks. Leica had markedly improved and she had a good obstetric outcome ultimately. So this is the paper which talks about reversible oligohydramnios in a pregnancy with angiotensin converting enzyme inhibitor exposure. So here at 27 weeks, it was noted that patient had severe oligohydramnios, and she was on benazepril. It was stopped and a healthy infant was delivered at term. So chronic hypertension, we have to be wary and inquire a great deal. And all these problems can be reversible if the agent is discontinued. And this is yet another paper which talks about diabetes insipidus in pregnancy. This is just a 14-year-old girl who was pregnant at 33 weeks. And then it was identified that she was not a known case of diabetes insipidus, that just diagnosed with oligohydramnios, but then determination of 24-hour urine volume because she had incessant polyuria and serum electrolytes identified this potentially reversible cause of oligohydramnios and poor obstetric outcome. Sometimes for blood, so we also said that kidney problems can be production problems or it can be a bladder outlet obstruction. So in some cases, sometimes we might have to even introduce vesico shunt. So a note about first trimester oligohydramnios. We always think amniotic fluid from second and third trimester, and we usually discuss cases about that for second trimester and third trimester. But then the etiology is unclear. Reduced amniotic fluid prior to 10 weeks is rare because fluid in the gestational sac is primarily from the fetal surface of the placenta, transamniotic flow from the maternal compartment, and secretions from the surface of the body of the embryo. So sort of coelomic fluid only. So first trimester diagnosis is rare. Criteria includes a difference between mean gestational sac size and crown rump length that is less than 5 millimeters, or a mean gestational sac diameter and CRL ratio outside the normal range for gestation. Reduced amniotic fluid volume in first trimester is an ominous finding, and pregnancy loss is the usual outcome. So to conclude, oligohydramnios is amniotic fluid less than the minimum for the gestation age. Thorough maternal and family history and targeted physical examination is helpful. Maternal medication history is vital. Rule out pre-labor premature rupture of membranes. Fetal anomalies and fetal growth restrictions should be looked for. Monitoring with single deepest vertical pocket and NST. Termination is pregnancy is decided by the etiological factors. Isolated oligohydramnios can be delivered at 39 weeks, and appropriate newborn care is mandatory. So thank you very much for the patient hearing. And I once again thank the Dr. Pundavi and Dr. Nitya for the opportunity. Thank you.
Thank you so much, ma'am, for your excellent presentation. There's a lot of queries regarding oligohydramnios. Can we take them at the end, ma'am, after the next presentation? Our next topic for today is cord around the neck. It is now my great pleasure to introduce our speaker, Dr. Suresh Seshadri, Director of Mediscan Systems, Chennai. With an extensive background in fetal medicines, he has many significant contributions to that field. Dr. Suresh sir has been at the forefront and has a wealth of knowledge to share with us. He has trained more than 4,000 doctors from India and other countries in ultrasound and fetal medicine. Over to you, sir.
Thank you. Are you able to hear me?
Yes, sir.
Okay, let me share my screen. My screen is visible?
Yes, sir.
Okay, good afternoon. Thank you very much for inviting me. And today's topic is nuchal cord, which is usually a hot question in every single conference that we attend. At the end of the meeting, everybody will ask, what about nuchal cord? So today what we'll do is we'll recap all the evidences that are available and about this nuchal cord and what is our role and responsibility in the same. About nuchal cord, there are several things which we need to know. One, of course, is we look at the water jelly, and you can see in patients with high drops, you can see the jelly becoming large, the cord becoming thicker, and as gestation age advances, the water jelly also increases in size. The next is the cord length. Normally, we do not measure the cord length, but we can identify a very, very short cord in cases of body stock anomaly. Then, more recently, people have started about what is called as the coiling index, which is the number of coils per centimeter of the cord. And here you can see a cord which is called as a hypercoiled cord. And then we are aware of a very important anastomosis called the hiatal anastomosis, which happens at the base of the umbilical cord, just before it enters the placenta, where there's a communication between the two umbilical arteries, which is why even with a single umbilical artery, the babies seem to grow reasonably well. And then single umbilical artery is something which we always look for while doing the scan. So there have been 57 studies with 830,000 participants. The incidence of nuchal cord is about 22%. It means a quarter of the babies which are pregnancies, you are going to see nuchal cord. 16% will have a single loop, and 2 loops, 3%, and more than 2 loops, it becomes 1% and less than 1% after that. Now, loose cord, 10% versus tight cord, 5%. The incidence diagnosed by ultrasound at any gestational age is around 28%, provided you are looking for it. Because the practice of whether we are looking for a cord routinely or no is something we will let you know as we go by. So here's the 32-year-old third gravida, first and second full-term normal delivery, third pregnancy at 22 weeks. And you can see the cross-section of the neck with the umbilical cord which seems to go around the neck. But again, there's a 33-week priming. Ultrasound reported one loop of cord seen close to the neck. And we really don't understand what this actually means. Because yes, there is a loop of cord, that's the neck. But you can see the cord is actually going away from the neck as compared to this cord which is actually encircling the neck. So this is a cord which we do not want to report, because in the next few minutes when the baby moves, this could go away from that point. Now let's look at 10 key messages about nuchal cord. How to identify nuchal cord on ultrasound, how good are we at diagnosis of nuchal cord, what are the types of nuchal cord, then nuchal cord and Apgar scores, nuchal cord and non-reactive fetal heart rate or CTG, nuchal cord and stillbirth, nuchal cord and neurological morbidity, nuchal cord and cardiorespiratory morbidity, also mode of delivery if there's a nuchal cord, and nuchal cord and medical legal issues. So these are things which we look at briefly. So we did our search query in our own database from 2012 to 2022. We had reported only 8 cases which was requested for an ultrasound, which means as a matter of policy, we don't routinely look for cord around the neck unless it is asked for. So let's see how to identify nuchal cord on ultrasound. We do a longitudinal and transverse section of the neck. A nuchal cord is diagnosed when the umbilical cord is visualized encircling at least 75% of the fetal neck circumference. If you take this as the neck and circumference, the cord should encircle at least 75%. Visualization of the cord encircling at least half of the neck may be classified as suspicious for the presence of nuchal cord. So we don't use the word loop of cord seen close to the neck. We always say, is there a suspicion of nuchal cord or no in any situation? Next, here are some other pictures, and you can see I am seeing a coronal section in this video, and in this coronal section, we can actually show that there are loops of cord seen on both sides of the neck. Right? And here there's a sagittal section where you can see a loop of cord or a cord, not a loop of cord, but a cord which is present behind the neck. But what is important to see is you can see the skin is actually compressed there. And you can see the skin which is compressed there. It's not a smooth skin. And that is an important sign which we will talk about presently. And here's a cord which, as I showed you earlier, which is going away, and this cord is going encircling around the neck. Right. Next is how sound is ultrasound in detecting nuchal cord. Out of 289 deliveries, 52 had a nuchal cord in this study. Ultrasound detected 18 out of 52, which is 35%, which means 65% of cords will go undetected. And 19% were false positive, were reported in the scan but negative at delivery. Extremely important. 19%, between 20% of the cords that are reported are actually false positive cords. Now, if you look at sensitivity and specificity, if you look at another study, we did 120 cases with 35 nuchal cords. Grayscale, 68% or 69% sensitivity with a specificity of 80%. If you use color Doppler, the sensitivity increases to around 83%. And if you use a 3D, it's about 71%. So color Doppler seems to be a method which will help you to increase the detection rate of nuchal cord. Now, let's look at complex umbilical cord entanglement. Now, it's a true knot of the umbilical cord, more than 3 loops of nuchal cord, a combination of true knot and a nuchal cord, and an umbilical cord entanglement, that is nuchal or true knot in the presence of a single umbilical artery. So in the presence of a single umbilical artery, if the nuchal cord becomes very tight, then certainly it can cause problems for the baby. So it's not only a nuchal cord we are thinking, but we are also looking at whether there's also a true knot associated with it. Now the diagnostic accuracy of another, if you look at a sort of a meta-analysis, it's about 12 papers, sensitivity of 80%, specificity of 86%. And there is actually no linear relationship between gestational age at ultrasound and accuracy. Now we are now seeing nuchal cords even at 12 weeks of gestation. But will that translate to a nuchal cord throughout pregnancy is something which we cannot say. Whereas performance in early labor, the sensitivity is better between 90 to 96%, because at that time the baby is not going to move around too much. So if you identify a cord around the neck, you're more likely to be in that area. Now, what are the types of nuchal cord? You have two cords. One is called as the type A cord, and you can see the type B cord. You can see the type A cord going down and then going above like that. In the type B cord, you can see this cord going on top of it and comes a full circle, and the top loop is above the thing. Now, what does it? Does it imply anything different? No, this has just been identified that way. But what is important to know, whether it's a loose cord or a tight cord, whether it's a single loop or multiple loops. Now, a 360-degree wrapping of the umbilical cord around the fetal neck, and at the time of birth, tight or loose, whether the loop can be manually reduced over the fetal head. So a tight cord is one where you're finding it difficult to reduce it manually over the fetal head, and a loose cord is one which you can do that. So here you can see a 360 degree. Also you can see there's one loop here and there's another loop going around. So this is, we can consider this as two loops of cord around the neck. Now, ultrasound cannot consistently and reliably distinguish between tight and loose nuchal cords. The indentation of the fetal neck suggests that the cord is tight. I'll go back to this first picture which I showed you, where you can see the skin of the neck is indented. Normally, when the cord is loose around the neck, you don't see this indentation, and this sign is called as the divot sign. Now, what do you mean by a divot? While playing golf, when they use the club and hit the ball, a small little cup-like excavation happens in the ground, and that's called as a divot. And so, if you see this divot, that means you know that the cord is compressing on the neck. And of course, it should be remembered that tightness may change during labor as the fetus descends through the birth canal. So you can report a loose nuchal cord, but as the lady goes into labor, it might become tightened. So we don't have, we cannot be sure for that. Now, what are the implications here? The concerns are impaired blood flow through the umbilical vein because of its relatively thin wall. Because a little bit of compression, the venous flow can be affected. Because generally there is unimpeded arterial flow from the fetus to the placenta, and fetal-placental blood volume, because it becomes reproportioned away from the fetus and into the placenta. So the umbilical artery is pushing blood into the placenta, but the return is not happening because the vein is a bit compressed, and that you can see causing deceleration. Right. Now, out of 219,000 live births in a 6-year period, 6.6% were charted as having a tight nuchal cord and 21.6% having a loose nuchal cord. And there were no differences in the demographic factors which are gestation at birth. You can see tight nuchal cord, loose nuchal cord, or no nuchal cord. The gestation age at birth does not vary. Similarly, primary gravida, there is no change. The race has no impact, and when there's a tight nuchal cord, there's a slightly higher chance of having a shoulder dystocia. Okay. Now, term neonates with a tight nuchal cord were slightly more likely to be admitted to an NICU. Here you can see 6.6% versus 5.3%. Or with no nuchal cord, about 5.9%. So a very small change which is there. Similarly, there is not much of a change in the dopamine in the first 24 hours. Maybe an RBC transfusion in the first 24 hours, again, there's not much of a significant change. So hypovolemia or anemia were not common among those with a tight nuchal cord. What about birth weight? Very low birth weight infants, which is less than 1,500 grams. The incidence of severe intraventricular hemorrhage, retinopathy of prematurity, periventricular leukomalacia, and early neonatal demise, there is absolutely no difference whether it's a tight, loose, or no nuchal cord. So, nuchal cord does not affect any of these factors as per the evidence that is available. So we can say no clinically significant differences in outcomes of neonates, nor in the subset of very low birth weight neonate delivered after a tight nuchal cord. So this paper said, we speculate that individuals providing care for neonates are not obligated to routinely order extra laboratory tests or conduct extra monitoring solely because of the report of a tight nuchal cord. So, but let's move on to single versus multiple loops. Now, this is a very large study of 42,800 women with singleton vertex vaginal delivery between 24 to 43 weeks of gestation. 8.9% had one loop of cord, 2.4% had two loops of cord, and 0.6% three loops of cord. Nuchal cord with three loops was an independent risk factor for operative vaginal delivery and Apgar score at less than 7 at 1 minute of life. A single nuchal cord was not associated with adverse perinatal outcome. So slowly we are moving to an area where we say when the nuchal cord shows 3 times around the neck, then there seems to be some kind of a risk, and the baby might be delivered with cesarean section. Now, a single loop of cord birth was associated only a 1 minute Apgar score of less than 7. Multiple loops of cord were associated with increased likelihood of cesarean section and Apgar score less than 7 at both 1 and 5 minutes. And tight loops of nuchal cord but not loose loops were associated with low Apgar scores. So again, the question becomes whether it's loose or tight seems to be the most relevant question. Now, for NICU admission, as we had already said, there is no evidence between nuchal cord at birth and NICU admission. Likelihood of NICU admission with a tight nuchal cord at birth was twice as high with no nuchal cord, although this was not statistically significant. So we are not sure whether NICU admission is really is there. Now, what about variability, fetal heart rate variability? With multiple nuchal cord, there's a higher incidence of non-reactive fetal heart rate, but it did not increase the risk of cesarean section or the poor nature of outcome in 1 and 5 minute Apgar scores, in spite of the difference in FHR variability. So this again, the evidence is not very strong in favor of the nuchal cord being reported or not. Now, we are also interested in what's going to happen to the baby, whether it will have a cerebral palsy, because we already spoke that if there's a compression of the umbilical vein, then there could be reduced blood supply to the fetus, oxygenated blood supply to the fetus, whether it caused the problem. Now, again, a very large study of 243,000 singleton deliveries with 14.5% nuchal cord at birth. There is no increased risk of cerebral palsy. Rate of non-reactive fetal heart rates was higher, but the nuchal cord group, but the Apgar scores and perinatal mortality rates were comparable to next to group. Very important from a medical legal point of view, because if somebody says the baby has cerebral palsy and the delivery note says there was a nuchal cord, they might want to link these two events, which we have to say that definitely they are not linked to each other. Right. Now, reporting bias. Now, let us look at elective versus systematic recording of nuchal cord in infants with low Apgar scores. Documentation of a tight nuchal cord was 6 times more likely with elective reporting than when the recording was systematic. Now, systematic recording of nuchal cord, significant association with cerebral palsy was not observed. So again, the way you report is also important. Now, nuchal cord and cardiorespiratory mobility. Again, in the last study of 248,000 cases, perinatal mortality rate, cardiovascular respiratory mobility, there was absolutely no difference. So no difference in cerebral palsy, no difference in perinatal mortality rate, and cardiorespiratory morbidity. So finally, they concluded by saying, further investigation following nuchal cord diagnosis or labor induction in an attempt to avoid complications when no sign of fetal distress are present seems unnecessary. So that nuchal cord at birth is not of significant adverse outcomes, even long-term outcomes. So they said you're not going to make any changes in the way you manage the patient. Now, we now have to look at the issue of bias, and after all, we are only human. We have one case which nuchal cord has gone into some adverse outcome. We immediately generalize it to all nuchal cords which are present, and we need to go by evidence-based. And because if we lose one baby and we think it's because of the nuchal cord, let's look at nuchal cord and stillbirth and the systematic review. There was no statistically significant association was detected between nuchal cord and stillbirth. And comparing to multiple loops to no loops, the odds ratio was about 1.9. Maybe that's a very marginal thing with this multiple loops. So overall, stillbirth rate is not increased with nuchal cords. And this, of course, is the data to support that. Now let's look at nuchal cord as a delivery mode. Cesarean section was significantly more likely in pregnancies with nuchal cord detected on ultrasound. So obviously, when we give a report of nuchal cord on ultrasound, more number of them will go for cesarean section. And higher rates of nuchal cord in the intrapartum cesarean section group compared with the elective cesarean delivery. And in the new analysis of cesarean delivery, we also found higher rates of non-reactive fetal heart rate in the nuchal cord group. Presence of nuchal cord may cause non-reactive fetal heart rate that leads to higher rate of emergency cesarean section. So, nuchal cord in postterm pregnancy and pre-induction of labor. Nuchal cord in postterm pregnancies is not associated with an increased risk for signs of fetal distress and operative intervention during labor and delivery. Nuchal cord is associated with category 2 electronic fetal monitoring parameters, which may drive increased rates of operative vaginal delivery. However, there is no significant association with neonatal morbidity. So conclusions are the evidence on nuchal cord, single, multiple, loose or tight. It's a random event. Long cord, excessive fetal movements can cause it. More common term and post-term. It's a very dynamic process. There is no association with fetal growth restriction. A single cord not associated with stillbirth. Multiple cord, we still have unclear data for us to take any concrete action on that. And there is no evidence that prenatal diagnosis may improve obstetric outcomes. Unexplained fetal compromise, we need to assess. And routine evaluation is not recommended because there's anxiety without clarity. I report a nuchal cord, and after that, the patient continuously feels, okay, there's something wrong the neck, the baby is going to get strangulated, and we'll be creating a huge amount of anxiety that routine reporting is best avoided, and incidental reported patients reassures the common finding and not associated adverse outcomes. And of course, we watch out for fetal movements. Thank you very much for your patience with me, and thank you for this opportunity. We're happy to answer any questions.
Thank you so much, sir, for the thought-provoking presentation. It has provided us with valuable perspectives and practical knowledge that we can all take away and apply in our practices. Dr. Shobana, ma'am, there are some questions to all three speakers. Yes. Can we take the questions?
Yeah.
Yeah. Shobana, ma'am, what is your practice regarding steroids?
So we give up to 35 weeks. And lowest gestational age will depend upon the situation. But generally, once the baby crosses 25 weeks, which is the rate of salvageable gestational age in our setup, we would give. If somebody is admitted with TPROM at 24 weeks, we'll wait till 25 weeks and then give the steroid. I'm sorry I did not include two important issues. Somehow it got missed in my presentation. One is diabetes and the other is twin gestation. So diabetes, there is a general concern because diabetes predisposes to infection and steroid is another reason for increasing the risk of infection. But we have not had any trial looking at corticosteroids in diabetic pregnancies per se, but it all comes out of subgroup analysis in the overall research trials. So diabetes is not a contraindication. That should be the bottom line. Diabetes is not a contraindication to give antenatal corticosteroids, particularly because diabetes causes delayed maturation of the surfactant, and therefore these are at increased risk of respiratory distress syndrome. But what we should be careful about is we should anticipate worsening of the hyperglycemia when we administer corticosteroids, which can last as much as 5 days after the administration of steroids. In fact, not the first day. After the second day, up to 5 days, it can manifest. So adjustment in the insulin or oral hypoglycemic agents will be necessary. Second subgroup is multiple gestation. The evidence is very conflicting, but overall, if you look at good studies and in the subgroup analysis of twin gestation, the same criteria that we apply to singleton gestation can be applied to multiple pregnancies as well. Again, a word of caution here, do not administer routinely on twin or multiple gestation because they are at high risk for preterm. Only if you have concrete or at least certain evidence that there may be a delivery in the next 1 week, less than 34 weeks, that is the time you will consider giving corticosteroids.
How about elective cesarean?
Sorry, it became an extension of my talk, but then, yeah.
How about elective cesarean sections, ma'am, at 37 weeks?
Yeah, so elective C-section I have covered, I think. Try to delay the cesarean section as much as possible to 39 weeks. But if you were to do between 37 and 39 weeks, again, we have to discuss the benefit and risk. There is a consistent finding of neonatal hypoglycemia, which is a risk factor for developmental delay. So be aware of that and aggressively look for it and treat it. But there is a benefit in terms of immediate respiratory morbidity, reduction in respiratory morbidity. Less babies in whom the steroids were administered will be admitted to the NICU for respiratory distress syndrome. Small but significant reduction is there. So overall, the incidence of respiratory morbidity in term infants is less than 5%, like I said. So really, it is not necessary. Overall, NICU admissions, mortality, nothing is affected. TTN is not affected. So that is the evidence that we have.
Thank you so much, ma'am. Dr. Shanti, ma'am, is oral desmopressin available in India? Is a question.
Nasal. I'm not well aware, but nasal is, I've seen people using them. Okay. And I've handled a patient long time back.
Yes, ma'am. And ma'am, measuring AFI is there, but you were telling about the ml. So they're asking if there's any, how do we correlate AFI to the volume in ml?
No. Amniotic fluid volume. That is how it is set. But then it is only STP or AFI.
Okay.
See, dye dilution technique, all that is only experimental.
Okay. Ma'am, and sildenafil, use of sildenafil, how many days sildenafil has to be given?
Oh, that is was done only for that isolated oligohydramnios, but that is also not guideline yet, especially after the Strider trial. 25 milligram 3 times a day for 7 days.
What about injection albumin 20% infusion in oligohydramnios?
That's what I went through all these things. But then, although it is commonly used, increased protein, all that, I could not find anything. So I did not mention about that only because.
No. Ma'am, and diclofenac ointment, can it be used?
Actually, we always say that even topical analgesic ointment should not be applied because that will really bring down the liquor. But then I searched a lot for papers. I could not get. But I also routinely tell, and our sonologists also specifically tell them. So I also tell. But then I could not find papers for topical thing. But whatever it is, some amount of analgesic is absorbed through skin too. So I think better not to use.
How about your practice regarding isolated oligohydramnios? How do you treat them, ma'am?
No, I wait.
I
wait. I monitor. Yeah.
IV hydration.
But pardon?
IV hydration and
hydration, oral hydration. See, earlier I myself only a few years now I know about although people were giving intravenous fluid for long, but then only now we get papers which talk about that as evidence-based. So usually what I do is just oral hydration and L-arginine to a certain extent. L-arginine I invariably use, although guidelines do not state that, but lot of papers are there. So these two, but you have to be careful with the drugs, especially now with all these elderly women. Lot of interactions can be there that we have to be careful.
Can I say something?
yes, sir.
Yeah.
Yes.
So this question about the diclofenac ointment, we have come across several cases. More recently, even last week, we had a patient. Whenever there is oligohydramnios, we scan the patient. We look at the kidneys and the bladder. If the kidneys and bladder are normal looking, kidney is normal, bladder is normal, then we say whether there's IUGR or no IUGR. No IUGR, baby is growing well. Doppler, ambulatory Doppler is normal. Then this is sort of unexplained oligohydramnios. There are two reasons which we have to think of. One, she is leaking fluid, or that she has taken NSAID. NSAID in any form. We've had a patient who applied diclofenac ointment only for 3 days because she had some back pain. The week before an ultrasound was done, the liquor was normal. The week after, liquor suddenly became severe oligohydramnios. And she continued to apply morning and evening. And then once we stopped everything, because it causes premature ductus arteriosus constriction and it causes renal shutdown, I think it should be avoided at all costs.
Yes, sir. The important take home being that a lot of women do complain of this low backache during pregnancy, and everybody thinks taking a topical ointment will benefit them, but we'll have to keep this in mind.
So we have to
Aspirin, ma'am, then?
them not to use them. Otherwise, they will just take it for granted. They will not tell us also.
Ma'am, Kundavi, ma'am, you want
Aspirin, what about aspirin then?
Aspirin up to 150 milligram is okay. ACOG talks about 82 milligram aspirin. Up to that is fine. That is what they say. Up to 150 milligram is okay. Arginine has interaction with that too.
Yes. Any more queries, ma'am?
Suresh, what is your advice for the radiologist? Would they really document saying that cord around the neck or?
Okay, So this cord around the neck in clinical practice has become a sort of chicken and egg story. Okay. Now, if you ask the people who are reporting, why are reporting, he says, well, my referring obstetrician asked me whether it is there or not there, so I am reporting it. Now, if they have not asked for it, they don't report it. But some people proactively report it. All I'm trying to tell you is they need to look at evidence, and in case a report is there, see, the bigger problem comes when a report is with you, if you did not ask for it, somebody has reported it already, and the patient is under your care, then what do? That is, do you act on it, and what do you do? So here we need to sort of sit and talk with the patient and tell them, well, there has been a report of cord of the neck, but current evidence says it's not of much concern. We will revisit you around 35, 36 weeks. At 36 weeks, we report specifically. We will look for it to see whether there is tight or loose cord, because tight cord is the only thing which is going to give us a little bit more concern as compared to a loose cord. And if we do that also during delivery, whether the cord will become tight or no, I don't know. So the whole thing is, this is not something which we panic, but because a cord around the neck has already been reported, there's a higher chance of cesarean section, the elective cesarean section. But this is the currently what is available, and we have to take it like that. It's only counseling in a detailed manner. That's why electively we don't go and report cord. We don't report. If somebody, a patient comes and they say this baby has got some deceleration, why don't do an ultrasound? At that time, we'll certainly look for it.
So there was a question in Shanti ma'am's presentation. Is there any correlation between the bladder volume and the oligohydramnios, or are there any studies?
So it is not the bladder volume. See, first of all, in the fetus, after 10 weeks, in every single scan, the fetal bladder must be visualized. Now, the presence of a bladder says kidney has produced some urine and it is collected in the bladder. The next thing we need to understand is called what is called a bladder recycling time. Now, if there is oligohydramnios and I see a bladder, I will wait for some time to see whether the bladder is emptying and filling back. And not see the visual inspection. You can do bladder. There are nomograms for bladder measurements at various gestation ages, but that's not something we need to do. We just have to see whether the bladder is recycling. If it is recycling, that is, you see an emptying of the bladder and filling. Sometimes the emptying will not be full, it will be partially empty, but still there will be change in size of the bladder per day. If it is there, we know the baby is passing urine. This is the information we know. So we have a situation where the reduced glycan baby is passing urine. We have to take it from there.
So there's another question, as in more than 2 loops of cord around the neck, should we report?
Yeah. So as I said, it's not a question. See, if you go purely from the imaging point of view, okay. Suppose somebody is an imaging specialist. The job of the imaging specialist is to see whatever they see, they have to report. Okay. Now there is somebody else who is going to act on that report. Now, whether to report or not to report, why are we even debating that? Because there is a concern that it leads to additional extra unnecessary sections. That's why whether this information, available information, are you providing more information than what is required for management of the pregnancy? That's where the debate is all about. Okay, so that's the question. Where if you are supposing during your scan you have identified it, there is no harm in putting it down and saying yes, I'm able to see loops of cord around the neck. But the significance is going to come whether it's tight or loose, more than 2 loops or 3 loops, and that's going to come in the last term, not in second trimester.
How would you proceed if there is an oligohydramnios when you scan them? What other things would you look for?
Oligohydramnios, we have a depending on the gestational age. Okay. Second trimester oligohydramnios. Now, first question you want to answer is it oligohydramnios, which means whether there is liker still present, some particle present, or it is anhydramnios. If it is anhydramnios in the second trimester, there are only two things I can think of. Okay, one is kidneys are absent or kidneys are non-functional, if the bladder is also absent. Second, if the bladder is present and I'm able to see kidneys, she is leaking fluid somewhere, we need to identify whether, because what happens is, she might have had a bout of amniotic fluid leak a couple of weeks ago, and after that, she said, one day I passed a lot of urine, after that nothing happened. But the fact is, once the sac is empty, the baby is producing very small quantities of urine. When it empties the bladder, it only 2 to 3 ml of urine is coming out. Okay. Now for these two things, if there is a leak in the membrane, this even if 10 ml collects, it's going to leak out, and that will go completely unnoticed. She won't be able to do that. So for me, is the bladder present? If the bladder is present, I'm going all out to see whether the baby is actually producing urine. I will look for filling and emptying of the bladder. Then I say renal function is all right. I have to look for other causes. Then I do uterine artery Doppler. Then I do umbilical artery Doppler. I do the growth. So I ruled out growth restriction. I ruled out everything. I ruled out a Doppler abnormality, placental dysfunction. And then I will come to the conclusion this has to be PRO only. That's the second trimester. Okay. Now, when I go to then of course the first question is history, that drug intake will always be taken. And we come to the third trimester. Now, late third trimester oligo is a physiological thing. It can suddenly, and that has been very well brought out in the lecture, that don't panic when there is late oligohydramnios, because it is not due to kidney. It is not due to kidney in sense, the kidney is not shut down or anything like that, because it's been functioning so well. And we need to take it with you do the Doppler, and then if it's a gradual drop in that for a period of time, it's not something that is not associated with growth restriction, I'll not be worried. If it is associated with growth restriction, again, it is not the liker which is going to dictate terms of what I'm going to do with the baby. It is the Doppler finding which is going to tell me what to do with the baby.
Thank you, sir. Ma'am, so you've answered the next question, Shanti ma'am. If a diabetic pregnant woman is receiving steroids, admit her and monitor. Okay. Yeah. Okay. I think all the questions are.
Yeah, I think I just replied to that question.
Yes. So as we come to the close of this webinar, it is my privilege to invite Dr. Geeta, Senior Consultant at IRM, to deliver the vote of thanks.
So, good evening, everybody. We have come to end of this session, and it's time to thank people. So, first of all, I would like to thank our head of the department, Dr. Kundavi ma'am, for providing this opportunity to deal with controversies. And I would offer my special thanks to all the speakers today. And thank you, Dr. Shobana ma'am, for clearing all the insights of antenatal corticosteroids, especially when and where we have to give, especially doubts in repeating the dose and also in varied obstetric situations. And a special thanks to Dr. Shanti ma'am for taking us through the journey of oligohydramnios and also how to tackle with it as per evidence. And I also extend my special thanks to Dr. Suresh sir, who cleared the concepts on removing the cord around our obstetric's neck, I should say, especially when we deal with such situations in our daily practice. And I'm sure everyone would agree to it. A special thanks to all the delegates for making the webinar lively with their question and answers forum. I would like to thank Sahiti and Chitrakala from Shield and also our EDP department to successfully complete this webinar without any technical issues. And special thanks to Dr. Nitya for organizing this webinar. And also I would like to thank our all-time mentor, I would say, Dr. Tamichelvi ma'am, to run this webinar. Thank you again, and see you all soon in the next webinar.
So as we conclude, I encourage everyone to take the knowledge gained here today and apply them in your day-to-day practice. Let's continue to learn, grow, and collaborate. Thank you all once again. Have a wonderful evening, and we all look forward to seeing you at our future events.
Thank you.
Thank you, ma'am.
Thank you very much.
Thank you, Shobna, Shanti ma'am, and Suresh sir for a lovely.
Thanks, Kundavi. Wonderful
message.
topics.
Yeah.
Thank you very much.
Thank you.